Okay, John, so as we were talking, I'm going to talk about guided surgery. And I like to call this presentation Guided Surgery for Dummies because I consider myself and all those around me real simple people, and we could be called dummies. So I always like to give credit where credit is due, and my staff really allow me to do these kinds of presentations. In fact, they push me to do these kinds of presentations. This is just a recent picture of our staff at one of our Christmas parties. And really what I want to start off is with this. Now, like guided surgery, implant dentistry has gone through an evolution. And it started off having all kinds of different implant systems out there. And we've gone from blades and from tripods and from subperiosteals to all kinds of implant systems. And not only implant systems, but also all kinds of implant materials, including zirconias. And basically, it's evolved, and everything that we do evolves. The kind of restorations that we make evolve. We've evolved from plastics on metals to zirconias with titanium to individual crowns on zirconia frames with ceramics. We've done all kinds of things over the years. And the one thing we have to remember is that everything in implant dentistry, in fact, in all of dentistry, continues to evolve. Now, when we started implant dentistry many years ago, implant dentistry was guided. And it was guided because we worked as a team. I worked with an oral surgeon or a periodontist. I told him where I wanted the implant, and I made him some kind of device that showed where I wanted the implant. And then the surgeon would go ahead and place the implant as close as possible to what I was looking for. So this just shows a picture of one of those guides. And we had all kinds of guides that we used to make in those days. This is another guide with a ring in it, which again gives a more exacting position for how I want the implant drilled.
And Isaac, please feel free to show me with your cursor particular points that you want to point out to this dummy, okay?
Okay, dummy. Okay, here we go. So what you're looking at here is in fact a ring, and into this ring go these bushings, and through these bushings go different sized drills. So with this kind of guide, you could drill the site and you would get some idea of where the implant would be, although depth you'd have to figure out by yourself. And this was really done this way before we had the CBCTs. And what's made one of the biggest differences to implant dentistry is the use of the CBCT. So with guidance, we would avoid these kind of situations. With guidance, we would avoid these implants that go in at some of these really odd angles. You know, we would avoid restorations that just make no sense because the implants are just in the wrong place. This picture here that I'm showing shows the implants coming straight out at you. They're actually at 90 degrees.
You're not serious.
No, I'm actually quite serious. I'm not sure how that happened exactly, but these are very difficult or sometimes impossible to restore. And this last radiograph that I'm showing shows an implant where the apex of the tooth is right near the head of the implant. So this was really placed much, much too deep. Although we had guidance, and we've always had guidance, sometimes the guidance wasn't as good as we wanted it to be.
It's like flying in the fog, essentially, you know, without the instrumentation.
Pretty much. I mean, here I was told that the surgeon used a guide to place these two implants. I'm not really sure what he used the guide for, but he used it. You know, here we have an implant going at an odd angle, and when you look in the mouth, in fact, the implant has perforated the buccal cortex. And again, sometimes implants just, I guess, go in upside down. I'm not sure exactly how this one happens. So we've used guides. They haven't been as strong. And some surgeons will come right out and say, listen, I know you send me a guide, but I don't use it. Or, thank you for the guide, but I placed it where I thought it should go. And that's not really the way this needs to work. The way this needs to work is the person making the restoration is supposed to guide where that implant goes. And if that implant can't be placed there, then what we need is bone grafting to make that work. Now, with all that being said, and using now CBCTs, we are able to produce guides that are so accurate and can be positioned in a very exacting way that we can drill through these guides and get implants exactly where we planned them. In fact, we can even make restorations for these implants in advance. And that's really how accurate this is. So I believe that where implant dentistry is today is the use of the CBCT to provide very solid guides so that we can do surgery and get the implant exactly where we plan it. That doesn't mean that we don't use our brains for brain guidance, but we do want to use these plastic devices for intraoral guidance. And these guides come in different forms. They come in the form of complete arches, or they come in the form of partial arches. And there are different programs that will make these kinds of guides. Here I'm just showing one of the programs. And over the years, the guides have developed into different formats where they've been developed with different sized rings to different depths. And through these, we can drill to exact location. And through many of these guides, we can actually place the implants to exact position.
So this is almost like a CAD CAM for creating the guide. Am I right?
It is, in fact, a CAD CAM for creating the guide. The guide is printed, and then the rings are connected. It is, in fact, CAD CAM.
Right.
Today, it's interesting. I'm talking about these plastic guides, but today we can actually use similar guidance concepts, as I'm showing here on these slides, where we can actually use a light overhead with these cameras connected, and the cameras will latch onto your handpiece and these little drawings on your handpiece. And when the camera sees that, it can combine your CBCT with your drill, and you can actually drill in either what they call 4D or 5D. And you can watch yourself drilling, not just on the patient, but you can watch yourself drilling on the CBCT. So in fact, you don't always need the plastic in the mouth, but you need the ability to connect all the pieces. And this system here, it's a new system, it's just being introduced, and this will give you also extremely accurate results based on your planning. So that's sort of where this technology goes. So computer-guided planning, computer-guided surgery, and then the restoration is really what we're talking about in implant dentistry today. In our office, in our patient population, 90% of our patients are being treated without raising flaps. Why? Because we know exactly where those implants are going. We don't have to see the bone. We know where it is. And that's when we're placing the implants.
And do patients like that idea of, not having to go through the flap raising and the more surgical trauma?
The patients love it. They don't bruise. There's almost no pain in these kind of situations. The procedure goes very, very quickly. Now, John, don't get me wrong. There's still some times where we have to raise flaps for a variety of reasons, but the majority of the cases, we do not have to raise flaps. And that is a big deal. To our patients, that's a really, really big deal. So when we choose our cases, obviously the case needs an implant. We need to make sure we have bone, and we need to make sure we have space, which means space between the teeth and space to get the drills in from an interocclusal perspective. We need to make sure we have attached gingiva. So if we go through the tissue, we have to make sure that there's still enough attached gingiva left that we're not going to run out of it once everything's healed. The mouths we have to be able to open our patients wide enough to fit these longer drills, and obviously the patients have to be able to afford it. There are some additional costs to the guides themselves. How's the sequence of treatment? Well, in this situation, we do our CBCT, we evaluate it for bone volume and density. We decide if there's a need for grafting. Sometimes we can do the grafting at the time of implant placement, or sometimes we do it in advance. We assess ourselves.
You have to raise a flap for that. You're not able to pull that one off.
No, if we need grafting, we are going to have to raise a flap, but sometimes we'll place the implant first, then raise the flap and add the grafting. Sometimes we'll do that.
Okay.
We need to assess the soft tissue, make sure that the implant will be stable based on the quality of bone that we see. And at that point, with the CBCT information, we can sort of decide if we're going to be able to make a temporary fixed restoration. From all that information, we can decide when we want to make our impression. In fact, because we're not raising flaps, we can make our impression on the day of surgery. And we can decide when we want to place our restoration. So all these things come into effect, and the CBCT is a really, really big deal when it comes to this.
Can I ask you a quick question?
Sure.
Just rough. What percentage of cases need grafting that you see?
I think in our practice, about 15% of cases need grafting.
So it's a minority rather than a majority.
It's small. We used to do a lot more grafting. But what we find is with the CBCT, with using very specific implants, even though there are undercuts in the bone, many times we can get around them. And we couldn't do that before without the CBCT. We couldn't do it.
Thank you.
Okay. So what you're looking at here is just an example of a complete edentulous guide. This sits on the gingival tissues. We drill through this, and we place our implants directly through this. There are no flaps needed for this kind of procedure. Using a similar technology, we can also do this for the partially edentulous, as is shown here, and we can also do it for single tooth applications. Just because it's a single tooth doesn't mean that that patient needs to have a flap raised. There's always a good reason to consider guided surgery in single tooth applications. And the biggest reason is to make sure that that implant doesn't hit the neighboring roots. And that's really the big thing. Now, we can take it one step further. Let's talk about certain more difficult situations. So the single tooth that needs to be extracted, and you want to extract it and place an implant immediately. So you want the CBCT so you can see exactly how much bone volume you have. You can then plan on that CBCT where you think the implant needs to go. You can then decide, is that implant the right one, or should I change it for something else? Maybe I should change it for an angled implant like you see here. Maybe I should go to a narrower angled implant. And ultimately, you choose the implant that you're looking for. You make your guide. And you take the guide. This is how the guide was designed based on this particular implant. And into this site, we're going to actually place an angled implant. So if you look here in this picture, you can see there's an implant in position, but access to that implant is through the incisal edge.
Right.
So we're going to use a bent implant so that when it is placed, we can access directly through the cingulum. And that's in fact what we're going to do. It's a very interesting implant. It's called a coaxis implant. And here we actually have it in place in the bone. And what happens is the head of the implant bends, in this case about 12 degrees, and gives us access through the cingulum.
So you're drawing me now to the photograph that's on my right here, is that correct?
That is correct. So here's the implant on the day of placement, and this is actually a temporary restoration that is on top of the implant, with screw access through the cingulum.
I see.
Okay. And I like to use this technology on immediate implants because if you look at these pictures, you can see whereas the ideal implant position shown here, you can see the angle that I'm going to screw my crown in on,
yes,
shown here,
yes,
and you can see the root that we are removing and where I'm in fact going to have a void between the bone and the implant. And I can decide if I'm going to need grafting or if I'm just going to leave it alone. So I can make these decisions in advance using this technology. And in this case, we extracted the tooth, we placed the angled implant, and again, in this screen here, you see we have a temporary that has access through the cingulum.
And in the previous case you showed, you were going to use grafting. Did you do that? Did you raise the flap beforehand and do the grafting beforehand, or did you do the grafting afterwards?
Well, in that situation, I didn't feel I needed to graft. There's enough evidence that suggests that if you don't raise a flap, and if the size or the size of the void is small enough, you don't actually have to pack bone in there. And it'll just fill in by itself, which is in fact what happened.
Right. Thank you.
Okay. Sometimes we'll look at the CBCT and we'll say, you know, this patient has a very sharp ridge. And if we're going to place our implant, we have to get rid of this ridge. So we will actually plan the implant lower. We will drill through all of this material so that we can place the implant in the appropriate position. So this gives us additional information. This kind of situation where if we place these implants, notice that on the buccal, we are going to have an area that is very, very thin. Whoops, excuse me. We're going to have an area that's very thin. And this is an area where we would place the implant and we would graft here at the same time. Because the part that's very, very thin is just mid-buccal on the implant itself.
Yeah.
These guides direct your drills to such an exact position that if you tried to do this freehand, you would have a real hard time. But because we're using them as jigs, we can drill through quite easily. So here's the guide, and there are the implants placed. Or in molar sites, you know, the molars take the greatest amount of force in the mouth. And when we're going to restore them with implants, we need to be thinking about what we are trying to do here. We're trying to give a large tooth some support. Sometimes we have to use a really big fat implant, as is shown here. Sometimes, if there's enough space, in fact, we will consider using 2 implants. 2 implants? Well, listen, the tooth that we took out had 2 roots. What's wrong with placing 2 implants? So as long as we can access those 2 implants, we can make a crown that sits on top of those 2 implants at the same time.
A single crown that incorporates both implants.
Exactly. So 2 implants are placed. And if you look here at this patient, look at the size of those masseter muscles.
Yeah.
You do not want to get your fingers caught between these teeth. So for her, we decided we would be best off placing 2 implants and a splinted reconstruction. And there are other benefits of splinting implants together. But in this particular situation, it's the occlusion that is the benefit. This implant has this tooth has 3 roots. Do we place 3 implants? No, I don't think we need to go that far, although I have seen people try it. 2 implants in a large space that will have a fairly large reconstruction. Now notice how big this tooth is. We were able to place 2 implants, restore the 2 implants, and we just treat them like 2 bicuspids rather than 1 molar. And we can do this in a very exacting fashion using this technology. No flaps are raised. There's no question where the implants are going. They're going to one place. This is total guided surgery, guided planning, guided placement. This is about the most accurate that we can get. And it doesn't leave a lot up to discussion. And that's really what I like. Are there possible issues? Occasionally there are, and they're usually soft tissue related. But in doing this for the past 7 years, we really haven't run into many issues at all. The biggest problems we run into is when a patient can't open up their mouth wide enough to accommodate the technology. That's the biggest issue.
Right.
So here, a tooth that's going to be removed, it's being measured, and we can place an implant into the extraction site using guided technology. Now, what's interesting is not only can you make use of placing implants close to each other, you can also avoid vital structures. So if you look here at the picture on the side, we're looking at the sinus. And what I'm going to want to do here is place 1 implant just behind the distal tooth and then 1 implant at an angle hugging the mesial part of the sinus. So here's the guide that we made up that allows us to do that. And this is all done by CAD/CAM. There are the angles of the implants that we're planning. And there's the placement of the implants. So we've got one implant as we wanted in a straight up and down position. And we have one implant that is just hugging the sinus. And then the head of the implant takes a bend, and we've got a 24-degree angle correction. Between those two implants, we can now create a structure that you see here that sits on those two implants, has 3 teeth on it. We've avoided the sinus. We've got a very, very strong reconstruction that looks like this.
Right.
And using guided technology, we can avoid sinuses, and we can do it extremely well. In this situation, once again, we're going to avoid sinus. So we're going to avoid sinus here. We're also going to place an immediate implant into this cuspid site over here. And we're going to place an implant on the other side, just under the sinus. And we're looking here at the 1-2 site. You know, someone might ask, why don't we add an implant in the 1-2 site? It's because look at the bone. There's really not a whole lot for us to play with. We didn't really feel like grafting in this situation. So we're going an immediate implant in the cuspid, angled implant to avoid the sinus on the right side. On the left side, an implant straight up and down that will be under the sinus.
Right.
That's what we've got planned. Here we're going through our planning process, showing the different slices through the planning software. This is the guide that we're going to make. And there are the implants that we're placing. So we've got one implant that is guided just in front of the sinus, and it takes a 12-degree correction. We've got a wider implant that goes into the socket of the cuspid. And we've got an implant that sits exactly under the sinus to support a restoration on the other side. There are the restorations.
And are those implants from different implant systems, or are they all from the one family?
The angled implant is from a different implant company, and the other ones are straight-walled implants, again, from a different family.
Okay, but you're combining different system implants, and you can do that now, yeah?
Yes, we are combining different system implants. What we are keeping intact, though, is the connections to all of these implants are the same. So all of the connections are, in this case, external hexes, and they all use the same kind of screws to hold things in place for simplicity.
Thank you.
Sometimes we've got a real tight squeeze. There is no way that you could do this freehand. In fact, I'm not even sure this is a good idea to begin with.
Mm-hmm.
But this was one of those situations where it was more than just a patient insistence situation. We were able to place an implant. We were able not to touch the roots. And we were able to go back and look at it 5 years later, and it's doing just fine. Of course, the molars got some problems, but that's another issue.
So what extra bit of advice did you give to that patient when you were putting that implant into that tight place?
I told the patient that the patient's best bet is to have a conventional bridge. That's what I told the patient. I told the patient that there is risk that I may touch the roots of the neighboring teeth and they may have difficulties. And I told her that the only technology that we have that is this exacting is the one that we used.
Okay.
It may work, it may not work. It is not my first choice for her, but she was really sold on the idea of doing it. She did not want her other teeth touched, so we did it. Similar ideas once again. In this case, this patient already has some implants in place. And if I show you the x-rays, the patient has an implant in a position such that makes placement of an implant, an additional one next to the cuspid, very difficult. In fact, this patient was told that they would go under surgery, under anesthesia, and they were told they would get 3 implants that would then allow them to have a fixed bridge. When the patient woke up, and the patient is a lawyer, patient woke up, patient was told by the surgeon, you cannot have a fixed bridge, you can only have an overdenture. You don't say things like that to a lawyer.
Especially when they're just waking up.
Absolutely. They weren't in the mood to hear that kind of news. So we saw this patient at the request of the patient's dentist, and we started planning to see if there's some way we can squeeze in additional implants. And using the technology, the CBCT and the guided surgery. So again, it's planning with CBCT and then creating a guide which limits and guides your surgery. Mechanically, it guides you, okay? And in doing that, we were able to plan this kind of additional implant support, which you see here. What we're going to do is we're going to squeeze one implant next to the central incisor and lingual to it and do an angle correction from the buccal to the palate. And we're going to place an implant just in front of the sinus. So we have something that looks like this. And in fact, that gave this patient the fixed bridge that the patient was promised. So in difficult situations, using this kind of technology, we can do some pretty incredible stuff. So when I first heard about this technology, I really wasn't sure, but you have to understand that this technology is extremely accurate. It's accurate, you can believe in it, you can do it. You're looking here at a picture of myself in one of our OR suites together with two of my assistants. This is Cheryl and this is Amber. And we're about to do a procedure for this particular patient. This is actually a demo procedure. And the picture next to it is actually, we're not doing implants here. Here we're actually in Uganda, and we're doing some extractions in Uganda. I thought I'd take an opportunity to throw that into the mix here, John. We do a trip to Uganda with Bridge to Health, where we take a large dental team and we extract teeth and we make dentures while we're out there. Yeah. I just thought I'd throw that one in. Again, believe in the technology, know that it works, and you can
appropriate technologies for different places, but the central theme here is belief in yourself and believe in what you're doing.
Absolutely, and that's pretty much what I have to say.
Well, Isaac, thank you ever so much for that most interesting presentation. If colleagues subsequently want to send us in questions, would you be prepared to with us answer those questions?
Anytime, John. It's a pleasure.
Reciprocated.
Take care.